All right, I think we can get started. We just hit 50 folks. Hello, everyone. Welcome to our April Moving Forward Nursing Home Quality Coalition conversation with Dr. Nicole Brandt. Alice will give her a fuller introduction, so I won't do that. But we are very, very excited about this conversation on nursing home pharmacy and nursing home pharmacists and how they do and can make nursing homes better places for residents and other staff. So Alice, I'll kick it over to you to take it away.
All right, fabulous. Well, welcome everybody. As we always say at the start of these coalition conversations, if you'd like, you can chat in your name and your organization or where you're from. We have a terrific mix of people on these calls generally, and today I see we have a couple of people who are live in nursing homes. We have people from our funder, the John A. Hartford Foundation. Welcome, Jane. Welcome, Nancy. Good to have you all. And we have, a group of, we have geriatricians and other professionals, really looking forward to hearing this conversation amongst all of us today with our wonderful speaker, Dr. Nicole Brandt. Before we get started, and we're going to do this a little bit interview style today. So I'm going to tee up some questions for Nicole and others who are on this call who've joined. But before we do that, Isaac and Sumeri and I just wanted to share a couple of updates from this week that you may be aware of or may not. So one of the things is we are working hard in these last few months of our current funding on getting some resources online through the Moving Forward Coalition website and some microsites, but just, sharing some of the work that's been done around federal policy recommendations that we've made. We've been doing a lot of work on CNA career pathway programs and apprenticeships. And I suspect people may know, but that Vice President Kamala Harris is in Wisconsin today, and she has announced that the final rule related to nursing home minimum staffing is now out and going to be shared. So you're going to hear a lot more about that over this next week. And then finally, both, the goals, preferences, and priorities committees work and the Committee on Strengthening Resident Councils. Those are two very active committees with the Moving Forward Coalition. Some of you on this call are part of those. And so we're going to be pulling together just sharing those documents and that information online more broadly with everybody. So you can look for that within the next couple of months and send us any questions that you have about that. Also wanted to flag that Senator Bob Casey introduced a bill last week on Monday, and it's about the long-term care workforce. And they invited Dr. Jasmine Travers, who's one of our committee co-chairs, to give testimony in person in Washington, D.C., which she did. And we can chat in the link to the U.S. Senate Special Committee on Aging website. They have the video up and online. So if you missed the testimony, Dr. Travers and a bunch of other terrific speakers gave testimony about the importance and urgency of addressing the nursing home workforce shortage and the shortage of workers across other settings as well, home care, et cetera. So if anybody else has other updates that you'd like to share, please feel free to chat them in, any updates from your own organizations related to any of the action plans that the coalition has been working on. We'd be delighted to have you do that. So with that, I think we'll get started with our topic and our conversation today. So it's my great pleasure to introduce Dr. Nicole Brandt, who is a colleague of mine for many years. I was just teasing her before everyone else jumped on the call that when I first met her and listened to her talk, I said to myself, oh my gosh, we have to find a way to work with this woman. She's so energetic. She's so committed. She's so passionate about this work. So I'm going to read a few things from her bio. I'm not going to read the whole thing because then the call would be over. But Dr. Brandt is a professor in the Department of Practice Sciences and Health Outcomes Research at the University of Maryland. And she's the executive director of the Peter Lamé Center on Drug Therapy and Aging at the university in the School of Pharmacy. And so, one of the things about Nikki is she's worked on lots of interdisciplinary teams across multiple practice settings. She's worked on the MedStar Center for Successful Aging program. She's really been an active advocate and promoted optimal care for older people through education, clinical work, and health policy. So she does all of those things, plus research. She has done a lot of work in the state of Maryland on age-friendly universities. And so the University of Maryland is now an age-friendly university, and it's due in large part to her work. She's directed a lot of projects focusing on Medicare Part D medication therapy. She taught me a lot about that management program. And she's co-authored, a lot of you are familiar with the American Geriatric Society Beers criteria. She has been a co-author of that for many years, and she's a past president and a board chair of the American Society of Consultant Pharmacists. She has worked to develop an implementation guide for post-acute and long-term care during the pandemic, and she's received the American Geriatric Society's Janigan Memorial Award for her leadership in geriatric education. So she is no slouch, let's just say, and she's contributed in major ways to our field and our work together. So I'm really glad so many people could join us today for this call. So Nikki, I will just extend a welcome to you.
Oh, thanks, Alice. And I always get humbled when someone reads my bio, and you did it so animated. Thank you. And for those of you who know me, know my biggest title is mom. So very active year for 2024. And so excited that, yes, we are a dynamic pair, Jade, when you put Alice and I in the same room, and that's where our Boston gathering came together. But we're excited. We roped in Dr. Chad Worse as well, who's the CEO of the American Society of Consultant Pharmacists. So thanks, Chad, for leaning in and joining us on this webinar. I know there's so many names on here, but I just have to do a shout out, Alice, to all the pharmacists that are joining us and some of our past leaders with ASCP. Lisa Morris is here. We just saw Rob Aceta in Boston, and I believe Laura Finn from the Pennsylvania area, just to name a few, but I know a couple other people joined us. So we're super excited. We want you to ask us questions. And as I was putting this kind of thoughts together, it's been wonderful to kind of reflect on the journey of the role of pharmacists in long-term care. And Alice, I don't know if I ever shared with you, but Sam Kidder, who worked for the Centers for Medicare and Medicaid Services when I did my sabbatical at CMS many years ago, even before your time there, he would get on the call and said, Nikki, you've always got to make sure that the pharmacist has a voice in long-term care and a role within the agency. So, so I'm happy to still work with the agency in terms of research efforts, but it's just so important that we work together on these important medication safety efforts. So I could go on, but I want you to lead the kind of conversation, and hopefully others will chime in as we get into this.
Yeah, thank you so much for setting it up with that those great introductory remarks. And again, as those of you who've been on these calls before know, we really encourage you to speak up and ask questions. Raise your hand if you can do the little hand icon. If not, raise your real hand, whatever. But just, chime in and ask questions, please. Nikki, I think you teed it up really well, talking about, some of your roles that you've played, and, how did you become a senior care pharmacist in the first place? Like, why did you decide to choose this particular, role as a pharmacist?
It's funny. I mentor so many students and trainees in my work at the University of Maryland through the years. When I reflect back, it was really opportunities. So I had an amazing mentor who worked within continuing care retirement organizations. And there was a program going on with the Visiting Nurses Association, with the VNAs. And this was before residencies and fellowships were as big in the profession of pharmacy. So I'm kind of dating myself for some of our younger members on this call. But I said, oh, hey, I would love to go out with nurses and do home visits. And these were assisted living facilities before they were regulated in the state of Maryland. And we were part of a research project looking at medication management and storage. And then I just got the bug. I loved the older adult stories. I loved the impact that you could have in these different care settings. And I just realized the safety aspect and people just truly wanting to age in place. So that just really kind of sparked my interest during my training, and then postgraduate training. I did a 1.5-year fellowship, and then just I just learned to always say yes. When opportunities were afforded to me on a state and then national level, from policy to practice. So that's where our paths crossed. We started on a state level working with the agencies, but I always kept my foot in practice. I feel as an educator and as someone who likes to inform public policy, I still practice. So that's where I've worked in VA settings. I've worked in long-term care settings, nursing homes, assisted livings, and I currently, as Alice mentioned, oversee services within the Center for Successful Aging with other pharmacists that spans both inpatient, outpatient, and long-term care. So, so I think it's really, really important. So that's where it started.
Great. And, it's so funny. We were just also talking before other people joined us, that you recently did a large program for over 300 people related to dementia, individuals who are living with dementia, and some of the non-pharmacologic interventions and approaches, and some of the medications that can be helpful. And so again, one of the things about you is you're always thinking about that interdisciplinary team. You're always, you're educating and advocating and talking about policy with not only other pharmacists, which you do a lot, which is great, but also, all these other roles. And again, I just chatted in that we have we have Rowena and others on the call who are CNAs. We have, again, Jeanette and others who are on the call who are living in nursing homes. We have advocates, but I think it's not everybody who really can continuously blend all of the different roles together. And do you have other thoughts on that, specifically around, how do we continue to promote the interprofessional team in nursing home work?
Oh, well, Alice, I think you just hit it on the head, is understanding who's on the team, right? And respecting all members of the team. When one of your questions, what's your favorite part of your job? And I would say is working on a team, and realizing your strengths and challenges, and then working with those others to help work through that. Pharmacists may not be present every day, but our CNAs and our nurses are. And so how do we work and communicate more effectively together? And oftentimes when we think about it, and I think about challenging team dynamics, but it's not about the team member, it's about the person we're caring for. And I think if we all stay grounded, and that's why I'm so excited about the work that we're doing together with the John A. Harford Foundation about person-centered care, what matters to that person, and then bringing the team together to really think about that. I think too often in healthcare, we're pushed by measures, right? And measures to see how adherent are we to treatment, how many people are taking certain medication classes, but that may not be person-centered necessarily. So I think that's a really important aspect of providing care in the nursing homes.
Yeah,
and I know we'll talk. Yeah.
No, I didn't mean to cut you off. I was going to say, I know a lot of times when I call you up about something, you often say, "Oh, I'm sorry, I'm late. I was with a resident. I was talking with someone." And I know you do a lot of that and keep it close. Again, I would say for the people on this call, interested in your thoughts and reflections, I don't hear a lot of people talking about maintaining a clinical practice once they've gone into policy. And I can really relate to what you're saying, Nikki, because, when you become part of state government or federal government in particular, or part of a nonprofit or a professional association, again, a lot of times some of us go into more policy roles and we are no longer practicing. So I think your point's really important, that it matters that people who are making policy really know the clinical practice in the current clinical practice. Do you want to add anything more about related to this sort of general topic about the collaborative practice opportunities that you've been part of or written in your times?
Oh, yeah. So, I know we're focusing on the pharmacist as part of the the bigger team. And every state's a little different, Alice, just because I know we have members across the country. And I encourage any of our members to chime in here because I know we have multiple states represented. But in the evolving healthcare arena, pharmacists can have collaborative practice agreements. And collaborative practice agreements can be, they have to, of course, maintain within the scope of practice of what a pharmacist can do. But I just know that some pharmacists in long-term care settings, and I know within our practice, we developed these collaborations with our nurse practitioners, with our physicians, to reduce the workload and burden of just making recommendations, but actually proposing changes, ordering labs, following up on some of the medication related needs. And I think that's a really important aspect of thinking about, we have a healthcare shortage of people trained in geriatrics and a healthcare shortage in long-term care settings. So how can we help that workforce? So collaborative practice agreements can be formalized on a state level. And I know with our practice, we have 5 collaborative practice agreements. And so I think that's important to note, and focusing on metabolic conditions like diabetes management, where pharmacists have been shown over and over again to help reduce hypoglycemia and improve what matters to people in terms of their disease state control, heart failure, COPD, neurocognitive disorders, the list goes on. But I think to think about chronic disease management and how pharmacists can help the team with that is really important. So that's one other aspect.
Yeah. No, that's great. And it kind of leads into one of the other topics we were going to ask you about, which is, there's been a lot written about care transitions. And when people go from home to the hospital, and then they go from the hospital to the skilled nursing, and then from the skilled unit, maybe to the long-term unit, et cetera, and lots of other combinations. But adverse medication events happen at a higher rate and with more serious consequences during those care transitions. People are going from one team of providers to another, one setting to another, sometimes physically. And there's just a lot of data that gets lost or mismanaged, or, even in the best case scenario, can be difficult to pull all the pieces together. So would you want to say anything more about kind of, discrepancies during transitions, or any programs you or Chad can chime in here too, have been involved with to sort of mitigate or eliminate even some of those errors?
Sure. Chad, do you want to take a stab at that first one, or do you want me to start?
You can start.
Okay. So I'm going to start with a story, Alice, of someone I saw last week. Okay. So I had 2 in the same day, and I thought to myself, oh my God, this couldn't have been more perfect. So the first was the wife came in with an older gentleman who had had a fall. He was in a nursing home. He had seen us before he went to the hospital. And unfortunately, with advancing dementia, it's not uncommon for them to have a fall. He has a fall. He's at the hospital. They change his meds. Goes from the hospital to subacute, short stay. They change his meds. And then he comes back to us, and his wife's like, I'm back on the medicines he was on before he went into the hospital, because they sent me 27 different scripts. Literally, I have the pile, 27 different scripts of medicines. And she goes, I don't know what to do. I don't know what all these are for. I think some of them are over the counter. I think some of them are prescription. I think some of them are the same. I don't know. I'm not a nurse. I'm not a pharmacist. Just help me know what I'm supposed to do. So we went through and we talk about whether it's deprescribe or represcribe or optimize. I'll call it medication optimization. But that's just one story. The other story was, and I see this, they go into the hospital, they stop their oral agents for diabetes, they put them on sliding scale or another type of insulin. Person goes home with this and they're so confused. I've never taken an injection before or insulin. How do I use this? Let alone what they paid out of pocket for the supplies and all the resources. So I could keep sharing stories. So I think we have seen through various practice care settings and different models of care where pharmacists or other team members are looking at within 48 to 72 hours during those transitions of care. So what's fantastic is what didn't used to exist is within health information exchanges, alerts can be sent to the provider team or that team saying, hey, let's follow up, because we know that medications are one of those top reasons for readmission. And just these stories just capture just brief examples, and I'm only in practice a day and a half, Alice, a week, two brief examples of where these misadventures, I'd like to call them, can happen because there's multiple people involved in prescribing. And I think this is where communication on your local level and relationships matter, because we've had to have conversations, our doctors with other doctors, about, hey, why are you changing all these antihypertensives? There's a great article that came out of the VA talking about people changing antihypertensives while they're in the hospital setting, that being perpetuated to the long-term care setting, and further changes happening. Then they go back home and they're more active, and either they're too sluggish or they're falling with these medication changes. So just thinking about those care transitions, and then also thinking about, we did an interesting quality improvement project with one of our local sites with what list is most accurate, medication list. So we see the list within the health system, we see the patients list, we see the HIE list, and the discrepancies. We published that a few years back. That same problem perpetuates. So I think we just need to think about how we're communicating amongst the providers, amongst the pharmacies, amongst the patients, and of course their family members that are managing that during those care transitions. So
and of course, dare we mention medication reconciliation and the requirements for that. That's usually generates quite a conversation. Chad, do you want to jump in here, and any other thoughts that you have related to these issues that Nikki outlined, the transitions in care, and any programs you're aware of in either the US or any countries that have really tried to sort of mitigate those?
Yeah, I think that when you look at what we're doing now with pharmacists, where we're deploying pharmacists, it's obviously the reach is extending outside of what might be traditional. I always remind people that for all of the hits that we take in the nursing home world, there are some advantages from a med management perspective. You generally have one pharmacy, you have a consultant pharmacist, you have a team of providers that is stable. You don't have a lot of specialists, and that scenario allows medication management to occur in a better way than maybe some other situations. So as our population grows and we only have so many nursing home spots, those spots are going to be taken up by people that are more and more sophisticated, more and more comorbidities, more and more medications. But that's going to push a lot of individuals, or allow a lot of individuals, to continue to age in assisted living and in the community. But their needs from a medication management perspective are not going to change. They're still going to need access to people like pharmacists, to individuals that have experience in older adult medicine, whether that's in transitions of care or just in your general primary practice. And we need those services for all of the reasons that Nikki explained in her examples. But just in general, as we deal with more and more medications, as we start thinking about medications by setting, what might solve your problem in an acute situation in a hospital from a medication perspective may not be the right medication for you long term. And somebody's got to be there to manage that process and make sure that you are either returned to the medication that works for you, or you evolve to a medication that works for you based on your individual situation. And that's sort of a new dynamic. We haven't had that for very long in terms of making decisions based on setting. So all of those scenarios really come back to another word that Nikki said, which was relationship, and how important it is that you have relationships with your primary care providers, with your pharmacists, so that they know you, and therefore they know how to help you manage medications in a better way.
Mm-hmm. Well, thank you so much for adding that, and a couple of folks have chimed in. So somebody asked about the collaborative practice agreements, which, as Cindy pointed out, can vary state to state depending on the practice acts and so forth, their state regs. The FASCP website, Laura wrote in, has a transitions of care toolkit with useful resources to focus on medication safety across these transitions. Thank you so much for mentioning that, so we can go look at that. And then Rob wrote in that pharmacists are providing real-time interventions during monthly reviews, medication reviews, to mitigate adverse drug events related to high-risk medications, which is amazing work. And gets back to a lot of the things that Chad and Nikki were just talking about. It's the relationships. When a PharmD comes into the building, when a pharmacist is there, when I was a nurse or a nurse practitioner, I made a beeline for that person because I had a list. I had a list of my questions that I wasn't sure about, or, I was thinking of doing something but wanted their input. And it really matters when you have somebody who you can trust, you know them, they know you, and you've got a relationship, as Chad just said. So thank you guys for chatting in all those things. I would say, in addition to what Chad and Nikki were talking about, Nikki, do you want to talk about the increase in the number of individuals who have serious mental illness or behavioral health issues who are now living in nursing homes? Because again, we know the population of individuals with SMI has, they've gotten a lot older, they're living longer, which is great. And they need, they need a comprehensive care plan when they come into the nursing home. Some nursing home teams have good experience, working with individuals with mental health challenges. Other nursing homes may not. And so they may benefit from, again, that relationship with the PharmD. Can you say more, anything more about, those nursing homes with a higher percentage of people with mental as well as physical challenges?
Oh, Alice, thank you for that. Yeah, we had a position paper we wrote in JAMDA on this, a call to action, really raising the attention of the increasing population. I should preface, I started my career in a lockdown psychiatric facility, and we know on a state level, there's been a lot of decrease in these facilities being present. So individuals were transferred into group homes or community homes, and now eventually into nursing homes, because we're seeing coexisting severe mental illness with neurocognitive issues, sometimes because of the medicines we might have exposed them to through the years. So I think we're all in this together. And I think the pharmacist, as your medication expert, can help you, because there's newer treatments coming all the time to manage severe mental illness. And I know sometimes our regulatory bodies are a little bit behind in terms of these additional indications for use, as well as additional formulations. But I know, and I'll do a shout out to our state, pharmacists are actually doing long acting injectables for antipsychotics to increase access and to help our individuals with severe mental illness. So pharmacists can help you to stay educated, to stay up to date, also can help you to really identify significant drug interactions. Thanks, Isaac, for telling them I'm from Maryland. So everybody knows Maryland. We've got a lot of TV shows, usually not that great, about some of our both substance use disorder problems and mental health issues, but anyways, I won't go there. But it's important to think about how we can, again, improve medicine safety. So pharmacists can help identify some significant drug-drug interactions. I know pharmacists can also help identify and monitor for the emergence of adverse events. And so some pharmacists are involved in helping with movement disorders, especially falls, when we think about the 4 M's. So again, we have an aging population. And I know Chad and I did a great seminar with FASCP about anticholinergic burden. And one of the speakers talked about individuals with developmental disabilities and thinking about that burden of these medications. And there's calculators and tools out there. So we can go on about the importance of including the pharmacist in those dialogues of medication and advanced care planning that needs to be a part of the care that we provide both in the nursing homes, assisted livings, and other long-term care settings.
Yeah, that's great. This is a great discussion. And before we move on to the next topic, which I know we want to talk about age-friendly health systems in nursing homes and some of the work that that you've been doing, I just wanted to pause for a moment and see if anybody in the audience wanted to ask a question or make a point about anything at all, particularly any of the things that Nikki and Chad and that we've all been talking about. And any thoughts from anybody? In addition, I've been chatting in who's on the call. I saw that we have somebody from the Ombudsman program who's also on the call. We've got a number of professional associations on the call. Again, QIO representatives, people from the state of Texas who have the QMP program. Isaac, you have a question. Go for it.
I have a question. I apologize for raising my hand, or well, doesn't matter. I was, we talk a lot about med techs in the coalition and the emergence of med techs in a number of states as an opportunity for career growth for CNAs and other workers in nursing homes, and to also spread around the responsibilities. And I'm wondering if, as a pharmacist in nursing homes and other long-term care sectors, you have any thoughts or suggestions about how states can roll out med tech programs effectively, thoughtfully, in well-integrated ways, et cetera.
I'll take the first stab at that, and then I'll let Chad answer. From my experience with med tech programs, the education needs to be dynamic and ongoing. This is not a one and done when it comes to training with medications. And I think with many individuals involved with administration of medicines, watching those medication passes is really important. And also to ensure accessibility, what to do if the meds are not accessible. And we've had some interactions where people ran out of meds for whatever reason, and what do you do in those cases? So I think there's a continuum of med tech advocacy, awareness, and education. But I think it has to be perpetual, because medicines are dynamic. And I know that some of trained nurses, especially when they're working with some of these different delivery systems, they're like, hey, Nikki, can you show me how to do that again? And I have to practice. There's different types of pen devices, there's different types of inhalers, there's different types of applications of different things, and even the modern devices, these continuous glucose monitors, the training that goes along with not just the medicines, but the medication monitoring. So I think we need to just have some currency, and also, and just to put people in positions where they feel like they're not just getting evaluated, but they're in work groups together, and they feel like there's a comfort with that training. But I think we just need to provide more support, because sometimes it can be a little unnerving, the complexity of these medication regimens, not just the amount, but the types.
I think it also, that also points out one of the issues that we have heard. And again, I know we have Rowena Shepard on our call today, who's one of our terrific committee members who works as a CNA. When people are CNAs or med aides or in that general category, although again, those roles are very different, they often will talk about getting adequate support and mentoring and just comradeship and collegiality from everybody on the team. And that means the nurses. Yes. Rowena, you may want to comment. It really matters that you feel like you're part of a team and you feel like you're being valued. And it doesn't feel like, oh, the nurses are saying, oh, we have med techs now, they're going to just do that. And they sort of, pass it off. Like, no, that's not the idea. It's a team. Everybody's working together. Everybody should be sharing information. What's changed about this resident today? What does this new medication mean? And again, a lot of that training people have had, but I think your point is so critical, Nikki, which is it's got to be ongoing. It's got to be dynamic. So Rowena, do you want to chime in here and add anything to this conversation?
Not really. I was just trying to listen.
All right. Well,
yeah. Teamwork every day.
Every day. You always remind us of that. Thank you so much. And Rowena comes with lots of stories about, her work with residents, and, it makes a huge difference. But, whether we're talking about, being a medication aide or a CNA, or again, it could be someone who works in nutrition, or there's so many different roles in the nursing home, and they're all really critical. They're all critical, and, for different reasons and in different ways. But, somebody from the business office can work directly with residents. We have walk to dine programs where somebody from, housekeeping could do. It can be throughout, and that's part of building the culture. But again, just because a PharmD is not in the building every single day does not mean they should be out of our minds, because it's just really, really important that they're part of the conversation. So, well,
Alice, one thing I just want to chime on to that. One thing I would say to individuals, whether they're family members, the patients themselves, direct care staff, I said, whenever you see a new symptom, ask if it's a medication side effect. I think we've heard that quote from the team up in Massachusetts, Dr. Gerwitz and others. Any new symptom should be considered a medication side effect. And I'll always remember this story. This is when Eliquis or Pixaban first came to market. And one of the nurses like, oh, you told me about this new drug, these bands, that they could cause bleeding. She's like, and I saw blood in the urine. She goes, do you think that's a problem? I'm like, oh yeah, that's a problem. So let's take a deeper dive into that. And it ended up, the person wasn't just bleeding. They were having some other types of signs of bleeding too. So even, see something, say something as simple as that, but to think of the medicines, because especially with the complexity of the medicines in our older adult. And that was, that was a direct care staff, a CNA. And she sometimes she felt marginalized, but it called empowerment. Every member of the team has a voice, and they're seeing things, people falling more, people after they take a medication, oh, I'm feeling like I can't eat, and they're the ones to tell you. So however you can get that voice to that care plan and to that rest of the team members, it's really important.
Yeah, and it's a great reminder about how critical every single person on the care team is, because again, we've heard so many stories, everybody on this call has, I'm sure, where it's somebody who's bringing clothes back to the room from the laundry, and the person living there says something to them that they forgot to say to anybody else. And so it really it matters that it's all part of a team. Well, I know we wanted to hear a little bit more about age-friendly health systems in nursing homes. I'm glad to report that we actually have 32 nursing homes signed up for our current action community on age-friendly, which is fantastic. But we have 15,000 around the country, so we still have others to bring together. But Nikki, if you want to start and just share about the new initiative that you've got focused on your work with pharmacists and age-friendly in nursing homes, and then others can chime in too.
Yeah, so this is really a team effort. And again, I want to thank our funders who are on the call, Jane and Nancy, who are supporting this call today from the John A. Hartford Foundation, who gave us this award starting in January. And this is in partnership with the American Society of Consultant Pharmacists. As Alice articulated, that's been my professional home throughout my career. And the Lamy Center at the University of Maryland has been working with ASCP for a long-standing period of time, both through training and other types of initiatives. So this was a natural fit for us to work together and hit the ground running in terms of using existing structures, regional meetings, webinars, other types of programs to leverage pharmacists in the age-friendly forums program. And we know that pharmacists are often a longstanding member on these teams that really can help bring the team together. We saw that with the antibiotic stewardship work. We saw that with the antipsychotic work in terms of quality improvement. So this is a 3-year program. And the first year is talking about educating pharmacists and other team members about the 4 M's and what can be done at the care sites. And this again could be nursing homes, assisted living, or other long-term care setting sites. So we've been going out to different regions. I know that Chad and a colleague of mine, Catherine, and I think Ronnie from the John A. Hartford Foundation will be in Houston this weekend. So we're just in Boston. So we're trying to empower and engage the base. And then to talk about bringing those teams together to put together 4 M's initiatives within their care setting. And that, as you know so well, Alice and Sumari and Isaac, the levels of engagement within the Institute for Healthcare Improvements work with the action community, so onboarding them. So I know, Alice, you and I talked about how we could look at the regional differences and how we could focus our efforts together. And that really comes because ASCP has been a leader, and I'm going to let Chad chime in here in terms of senior care pharmacy. So Chad, I'm going to turn it over to you to expand upon that.
Thanks, Nikki. I guess to expand on that, I would just say that, the American Society of Consultant Pharmacists has been around for 55 years, and its whole mission has been to transform aging and empower people with medication management. And so to work with the John A. Hartford Foundation and work with people like Nikki from the Lamy Center on championing pharmacists to be able to bring that age-friendly movement to nursing facilities, to assisted living centers, to long-term care pharmacies, and other settings where we take care of older adults is a thrill for us. I mean, I feel like it's part of what we do as pharmacists and pharmacies that work in this space. So from our perspective, this falls right in line with the kind of education and efforts that we're trying to make to improve medication management for older adults and some of the medically complex patients we treat.
Great. Laying out of this, the age-friendly work. And, we're always talking about it when we're talking about the Moving Forward Coalition, because it ties very closely. It's woven together so tightly. The what matters questions in age-friendly are tied very closely to our work on asking residents about their goals and priorities when they first come to the nursing home and things like that. So lots and lots of overlap. And of course, you guys were both just talking about the medications and how, questions about the medications and the whole team. So I think it'll be really interesting to see what happens with the pharmacists being a key element of promoting age-friendly care in nursing homes. As we said, every single person can be part of it, but pharmacists obviously have a unique role when it comes to, collaborating around the medications. Speaking of a unique role of pharmacists, I don't know, Nikki, if you can see Summer Valenti's question in the chat, but do you want to, or Summer, I don't know if you want to come off mute and say a little bit more. So this is a question, folks, about methadone. So Nikki, do you want to, so the
Sure,
question
I could.
has to do with it. Oh, there you are. Go ahead.
Yeah.
Summer.
So it was just recently, we do accept at our SNF, we accept patients who are on methadone therapy. Typically they have been people who have been set up in the community prior to us accepting them, but we recently got a resident who was at a assisted living, and there the physician had prescribed the methadone with the indication that it was for pain management, and the pharmacy had been dispensing it. He was hospitalized, and at that point the hospital records caught up to him and revealed that there was substance use disorder history. And we took him as a patient, but were not fully aware of the history. I don't want to discriminate against a patient. We want to take them and provide them with the medication that they need, which is prescribed for them and appropriate. But we had a very difficult time. The pharmacy absolutely refused to dispense. It was on a Friday. We couldn't get him intake to a community program. And he went all weekend on a substitute opioid because of that, which it just seems like a terrible falling apart of the system. And I understand the pharmacy's policy is their policy, but it really, I felt handcuffed, and the family was very upset and the patient was very upset. And it's the opposite of what we're supposed to do. Now we just put him on, the oxycodone, which is the thing he had the problem with, because it was the only thing we could get through the weekend.
Yeah.
Yeah, Chad, I don't know if you want to speak because we just did our
Sure.
fly-in. Yeah, but you can start and then I can talk about some of the things we're doing here. So go ahead.
Okay, but not to rush to the defense of the pharmacy, but in those situations, it actually makes a difference on whether you're using the methadone for pain or if you're using it to treat opioid addiction. So in the case of treating for opioid addiction, a pharmacy cannot dispense methadone. That's not a pharmacy policy, that's a drug enforcement agency national rule. And it's one that we have been very active at ASCP at trying to change the long-term care setting, because ultimately what you experienced is what we worry about, which is if you have somebody being treated with methadone for opioid use disorder, you actually have to arrange to take them physically to the facility, the clinic that they're enrolled with every day to be dosed on their methadone, which, as all of us probably would guess, is pretty much impossible for people that are in nursing facilities and that are living in nursing homes. So unfortunately, that rule still exists. That's the one that's enforced, and the DEA is not one to look past that rules, which is why you see the resistance from the pharmacy. Now, if it were actually being used for pain, it seems odd, but we can use methadone and dispense it from pharmacies for people that are using it for pain. But that's the way the rule exists right now, and it's just unfortunate, and one that we're really working hard to try to fix for long-term care.
And Summer, just to add a different angle to the conversation, because I know you talked about methadone, but there's been increasing utilization of buprenorphine and Suboxone for helping for opioid use disorders. And I have to tell you, that's what we've been doing at a state level, and we've done some demonstrations within our long-term care sites to improve accessibility. There's been a lot more education. As you know, there's been a little bit of ability for more prescribers to get access to that as an option for opioid use disorders. And I have to tell you that having done both methadone and buprenorphine, and for older adults, I tend to like the latter. It tends to be a safer option. And there's some good literature with it in older adults in particular. So, but yes, I know I wanted to let Chad chime in because he's been doing a lot with the organization and their team with the DEA.
And I'll just follow that up real quick, Nikki, with if you do, the use of Suboxone is much easier. It is more traditional that can be used by long-term care pharmacies. So you don't have the same restrictions as you do with methadone.
Yeah, the pharmacy does dispense Suboxone for our long-term care pharmacy does, and actually have two local clinics that once we get the patient through intake, will allow us to pick up the medication in a drop box once in a lockbox once a week. So it has to be someone that they've drug tested the driver and got a criminal background check that works for us, and they can pick up. So they don't have to go daily in our situation, which is wonderful. I don't know what the regulations are in other states, but in New Jersey, we're able to do that. But we do have to get them through the intake. And when we get a patient on a Friday, it's just impossible.
It's another example. This is a great conversation. I think it's just another example of these, newer subpopulations that are growing in numbers in some nursing homes, not all, but in some. And, if you are one of those nursing homes, you're coming up against some of the regulations that perhaps were not intended to be overly restrictive, but are not enabling you to meet the needs of the clients you're taking in. So I think the alternative ideas that Chad and Nikki, presented are some thoughts. They may not be perfect in all situations, though. And again, it's good to know that people are looking at these policies and seeing if, there's ways to update. Rob Aceta just put in, there's a great resource, care of residents with opioid and stimulant use disorders in long-term care settings. So there you go, mass.gov. So again, just let's continue with those thoughts. I think, again, there's nursing homes that have, traumatic brain injury, people with traumatic brain injury primarily. There's ones that have younger population and more individuals with disabilities than, older people. But again, it's different all over. So thank you for those questions, Summer. That's great.
Yeah, Summer, thank you for that, because I think it illustrates the importance of the team from an advocacy perspective. I know some of the questions Alice had prepared me for is like, how can the pharmacists work with your team? So advocacy, education, and awareness to community resources is so critical. But I know Jane's got her hand raised. So Jane.
I don't want to take us off track here, Alice.
Go for it. Go for it.
But when I went to the ASCP regional meeting, I was fascinated at the artificial intelligence conversation. It was so well done and well presented. And I was very hopeful when we were talking about med reconciliation or some of these things that take a lot of time or aren't that perfect. I just wanted to say if Nikki or Chad wanted to make a comment about the opportunity that AI presents itself into certain aspects of healthcare as well as pharmacy care.
Do you guys want to make a comment? Go ahead.
So yeah, so Jane had the privilege, one of our regional team members from Connecticut has been doing some work on the state level, but also on a national level with AI. I think one of the things when it comes to artificial intelligence and large machine learning, and I am not an expert, but we've been doing some focused conversations with some thought leaders in this space, is about the quality of the data. And we know that sometimes, as we talked about earlier, sometimes these medication lists aren't entirely accurate. So, so just being mindful of where that data is coming from, but they're getting better. And then using some of the risk tools to help stratify people that are at greatest risk and then to look at that. So there are emerging tools. And I think as we think about them into our workplace, I think it's an opportunity to improve the processes. But I still believe strongly, Jane and others, that this is my perspective. You need the human touch to make it person-centered and understand what their goals of care are. And it's going to be like any other tool. It's like the Beers criteria. It's integrated in the EHR, but unless you use that tool in a meaningful way, it may not be a good tool. So I think that's kind of the thing to think about. And I don't know, Chad, if you want to add any more to that regarding AI and some of the work that ASCP is doing.
Yeah, I mean, I think I would just echo your comments. I think that AI will become a profound tool in the hands of clinicians. I think, again, to your point, the last mile is still a human's ability to take that information and apply it to another human. I think that our challenges still exist with interoperability of data sets and systems, because no artificial intelligence, not even the existing systems that we have to do safety checks, work efficiently if the different dispergent systems that we use aren't talking to each other. So I think we have a ways to go. There's the promise that AI can take us another maybe exponential step forward. But the basics of, does Epic talk to point-click care? Does the pharmacy software talk to these different systems? And can you pull the information in such a way that it's reliable so that AI and AI-like systems can help make good decisions and put those in the hands of the clinicians taking care of people?
Well said, for sure. And, again, the AI conversations cannot be short and sweet. That's not, it's a big issue and has a lot of complexities, but, keeping the human aspect there as well in the conversation is really important. I know we've got about 7 minutes left. I wanted to ask, I know, again, Jeanette, I know you're here in your role as a resident and as a steering committee member for moving forward. I just wanted to see if you had anything that you might want to add to the conversation today.
You're on mute. I can't hear you.
Can we unmute Jeanette? We'll try to unmute you. Hang on. See if we can do it. Might take us a minute.
No problem. I always love the voices of the steering committee and other stakeholders.
We can't unmute other folks, unfortunately.
Okay. All
We
right.
can
Sorry,
only
Jeanette. That's on us. Well, we'll catch you and do follow up with you anyway. If anybody else who's on the call, I know we have Nancy Tutors, who's part of NADANA. I know we have Suzanne Messenger, who's with the Long-Term Care Ombudsman Program, Kathy McKenna, who used to do surveys, Brian Duke from Pennsylvania. Anybody at all. I'm just recognizing some of the folks we've worked with through the coalition, but any questions for Dr. Brandt or Dr. Wartz related to any of this? We have Nitch on the phone. I see Karen's on the phone from Nitch.
Karen was mentioning she was at MedStar before, so a shout out, Karen. Thanks for that note. It's a small world out in healthcare.
And if we don't have specific comments from other folks, I would just
a quick comment. I was recently interviewed by case management industry piece, and one of the concerns the the challenges, and it really sounds very similar to something Summer was experiencing, was as the patient transitions from one setting to another, there seems to be a lag time with filling meds. Are there any strategies around that? I told her that often it has to do with the availability and the cross formulary issues that we see, but I was wondering if there's any work going on. But it's great to see you, Nicole, and look forward to collaborating with you more.
Absolutely. Thanks, Karen. It's good to see you as well. You know, I think that's a really important point. As Chad was just alluding to, depending which care setting they're going to and when those medicines were filled, sometimes the payer doesn't know that there was a transition, that they were somewhere else, especially in Medicare Part D. So if they did a 90-day supply of a medicine, they may say, you've already got that medicine. And I also think we need to be very mindful. There's a very big medication shortage out there, some particular medicines that's really putting pressure on prescribers and patients and the systems at a large. So there's multiple facets to that, Karen. I don't think there's one answer, but I know that there's a meds to beds program that sometimes hospitals or long-term care will do to ensure that they don't run out of medicines. And I think that's a really great program. But I always loved when our family members who we knew were going to be going home could bring in their medicines, and if we could reconcile with them, you know, some of those changes. I know technically you can't administer those meds, but there could be some really good bedside education that could be done, just like we do in hospital settings. And I really think we need to think about that, because oftentimes the complexity of the meds increase in the nursing homes because we're prescribing over-the-counter agents, and people view it as prescription, but they're really not. And so the families get very confused. So there's a lot of angles to that question, Karen, but I think a lot of it really hinges on who's the payer of the medicines. And then as they transition, how are they getting reimbursed for those? And that's a complex equation.
That's great information. Thanks.
Yeah,
Yeah.
thank you so much. And as we wrap up here, I think we're going to turn it over to Dr. Jane Carmody for the Johnny Hartford Foundation. I know, again, we've also got Nancy Wexler and Dr. Cheryl Phillips on the call. Any comments, Jane? I know you've been around listening to all these different conversations around the country, but final thoughts?
Thank you so much. This has been so great. And Cheryl, I'm sorry we got you on late, but I know you had another conflict, so thank goodness you're here. And Nancy's here. Cheryl and I are supporting Nikki and Chad in this great new grant for pharmacy and nursing homes. I am sorry for bringing up AI, but I'm all about it.
We loved it.
Something.
It's all good, Jane. And Alice, as we build out some of these tools, we will be, as you know, sharing them with you and your team here, because this is resource exchange. So we're super excited to be working together. So I just want to say thank you for giving us the opportunity to share and to reconnect with people across the country. This is awesome. It really is a small world. And I just want to thank you for that. And I want to thank Chad for roping him in last minute to come join this conversation as well.
Well, thank you.
Match made heaven.
Yes, thank you
Happy
so
to.
much, Nikki and Chad and everybody who's joined the call and all of your comments. Cindy put another great comment in here, and Jennifer had a resource also for Summer and for everybody. This was a great call. We're so appreciative, and hopefully it'll keep the conversation going. So we can share information for Nikki and Chad if you didn't get to ask your questions, and just really want to say thanks to everybody who's working on teams to improve quality of life for people living and working in nursing homes. So we are grateful, truly grateful. Thank you all so much. Have a great rest of your week. Thanks to Isaac and Sumeri for organizing us every day. Thank you.
Thank you.
Thanks, Alice.
Great call. Thank you.